My colleague James may be joining us a little bit later on to talk through some of the cases, but it's going to be mainly me. My name's Jo Hayes. I'm consultant in palliative medicine based in the Marie Curie Hospice in Penarth, but actually clinical role in specialist palliative care community team and in the acute hospital. And so I see people in either of those settings and sometimes both as they come in and out of hospital. There's a lot of slides here, so apologies for going a little bit quickly through some of them. I think we probably need to dwell more on cases rather than pain pathways, so I make no apologies for flipping quickly through those things. All of the sessions are recorded, and should anybody want to watch again, it will all be there for you. Thank you. So the aims for this session are to talk a little bit about general pain stuff, classification, how to assess people. And when I say people, I mean palliative care type patients or people with progressive and incurable disease. Some of the analgesics and strong opioids that we might use and more difficult pains, and then run that through a case study, which goes through lots of different aspects towards the end. Before we start talking about definitions of pain, Charlotte, I wonder if it's useful to run the polls. Would that be okay? Just see who we've got on the call. Are you there, Charlotte?
Yes, can you see that?
No, I can't. Can anybody put in the chat whether they can see the polls or not?
We've got 50% GP and 50% palliative care team.
Great, thank you very much. And the second poll, you just read out the answers to me. I can't see them at the moment.
Hang on, let's launch that one.
Yeah.
And in what setting do you work? We've got 100% community. Sorry, no, it's changing. 67 community, 33 mainly specialist palliative care.
Okay. And my specialist palliative care colleagues are probably working in a mixture of settings, I would have thought. Thank you very much. Do ask questions as we go, even though some of this is going to be quite quick, and put stuff in the chat. Charlotte's going to man that and can interrupt me when needed. So apologies if I'm telling some of you stuff that you already know and it's basic, but we'll just go through quite quickly. So pain, an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And as we all know, it's modified by mood, morale, and the meaning of pain to the patient. It's what the patient says hurts. So if you're feeling quite low in mood, depressed or anxious, or there's lots of very difficult stuff going on, then the pain may well feel worse. If you're distracted, then pain is often better. This is why rugby players will not notice their broken fingers until they come off the pitch. This is why at night, when you're not doing anything else and things can play on your mind, pain can sometimes be worse. And the meaning of pain to patients, for lots of our palliative care patients with things like cancer or progressive neurological disease, the pain's a sort of constant reminder that you're not well, that things are getting worse, that time might be short. So the meaning takes on something completely different to, if you have injured yourself and that's hurting you. Okay, so lots of us will be very well aware of slides like this, that pain is multidimensional. Yes, it's got a physical element, which is affected by, things like mood, insomnia, but there's also a psychological element. Lots of people are angry about things that have happened to them. Lots of people are frightened. Lots of people feel hopeless, helpless, and are anxious. There's a social connotation to pain, so concern about your role in the family, your earning potential, feeling abandoned and isolated, and a spiritual component as well. And we all know that spiritual elements and spiritual needs are not just about formalised religion. And for increasing numbers of people in the UK, a form of religion might not be terribly important in their lives, or it may be, but spiritual is more sort of existential stuff. And, you know, why has this happened to me? I didn't drink, I didn't smoke, I've led a good life, I've tried to be healthy. Why is it that this has happened to me? It's not fair. So all of those elements feed into this concept of total pain. And this is why a medicine isn't necessarily going to fix the problem, because it's got all of these complex elements feeding in, and therefore you need a sort of multi-dimensional approach to pain, and probably a multidisciplinary approach with different people in your team. So I would like to think I'm reasonably good at assessing and treating physical aspects of pain, but I'm not going to be so good at addressing psychological needs. And I have got colleagues on the counselling psychology side who will be able to do that much better. And so as a team, we're stronger. I've got people who work as social workers. I have got spiritual needs coordinator. And as a team, we can address all of the different elements in a better way. So this quote is just an illustration of pain, really, and an illustration of the advantages and disadvantages of scoring systems, I suppose. How does one begin to describe a pain of 15 on a scale of 0 to 10? Which pain is it that you want to know about? The pain in my belly, the pain in my soul, the pain in my family's face? And that's why your analog schools might not always tell the whole story. But in your asking, I feel humbled, valued, acknowledged, and I believe that despite your hectic day, you pause to recognise me as a person, not only with a dreaded disease, but living in pain. So how common is pain? I'd be really grateful if everyone could mute themselves, if that's okay, because we're getting a little bit of background noise. 3/4 of cancer patients have pain. Only a third have one pain. Lots of people have more than one pain. And interestingly, the incidence of pain in palliative care patients with non-malignant disease is sort of 65% plus, so actually not very different from the cancer patients. So I think that illustrates what lots of us who work in palliative care and sort of more generalist clinical care know, in that just as many palliative care patients who don't have cancer will have pain compared to the cancer patient. Okay. Causes of pain. I've always found it very useful to split things up in these sorts of categories. The disease itself, the treatment, something unrelated. So that might mean that it's constipation causing the pain. You know, it's not the disease itself and it's not the treatment, but it is something else. Or just related to general debility and frailty. Okay. And in one series, in 15% of patients with advanced cancer and pain, none of their pain was caused by the cancer itself. I've got a couple of patients at the moment who've got cancer and metastatic bone disease, known disease in their spine, lots of back pain. But actually, when you MRI their spines to try to see exactly what's going on and whether it might be helpful to think about some radiotherapy, they've actually got some cancer, but well away from the pain. And what it looks like is causing their pain is lots of degenerative disease in their spine, disc problems and nerve impingement, and therefore palliative radiotherapy is probably not going to be helpful. But you know, we need to help them to manage their pain as a whole person, and choose analgesics appropriately. Okay, so this is the sort of stuff I'm going to skip over, really. Yeah, there's lots of nerves, and it's them firing that cause pain. You can be stimulated and sensitized by lots of things: cancer, inflammatory responses, tissue injury. Nerves relay pain messages up to your brain, and opioid receptors. If you stimulate opioid receptors, they sort of modulate or interrupt that pain pathway and can reduce the amount of pain messages that get through to your brain. Okay. So classification of pain can be quite helpful. So nociceptive pain is associated with tissue distortion or injury. So that would be the sort of pain that you might get if you have, say you've got lung cancer on the left-hand side. So you'd have a sort of poorly localized, general achy sort of pain on the left-hand side of your chest, which responds to morphine. So that's a sort of nociceptive pain. Or you have got liver secondaries if you've got cancer and you have got tenderness over the right-hand side of your abdomen when people sort of press on your liver. That's another example of a nociceptive pain. Okay. Neuropathic pain is a pain that results from nerve compression or nerve injury. So lots of neuropathic pain in palliative care, but also lots of neuropathic pain in non-palliative care patients. Sciatica is probably one of the most sort of well-known neuropathic pains. So it's pain as a result of a nerve compression or nerve injury, and the nature of that pain is often different to nociceptive pain in that instead of a sort of poorly localized achy sensation, it may well be pain that burns or stabs or shoots. It might be associated with altered sensation. So people that have sciatica may have a bit of numbness in their foot on that side. It responds less well to morphine. Morphine's really helpful for neuropathic pain, but it might be that you need something extra as well to really get on top of the pain. An example of non-cancer neuropathic pain are things like diabetic neuropathy. We've also already talked about sciatica, or post-shingles pain. Post-herpetic neuralgia is another example. Neuropathic pain can be quite unpleasant, and therefore it's good to diagnose it and good to have an awareness of the different types of painkillers that you might be able to use for it. Okay. So we've got nociceptive pain, we've got neuropathic pain, we've got other pains that have got sort of particular features. So when you're talking to your patients and asking them what the pain is like, depending on what they tell you back, you may be able to work out what sort of a pain it is. So bone pain, well localized, tender. So if you press on a certain bit of your back and it's sore, or a certain part of your hip and it's sore, that may well be indicating bone pain. Tends to be constant nagging, often worse at night, often worse with movement because you're moving your bones and trying to put weight through them. Whereas colicky pain, so colicky abdominal pain, as an example, if you're very constipated or if you've got bowel obstruction, you can get colicky abdominal pain, tends to occur in spasms. And if it's ladies who've had children that are talking to you about their colicky pain, they do often liken it to labour pain in that it sort of comes and goes in waves and it will settle down, but then you can feel it building up again and it'll build up to a peak and then reduce again. And you can imagine if your bowel's trying to sort of push something along, then those waves correspond with the peristalsis in your gut. You can also get colicky pain in other places. So people with gallbladder trouble, for example, might get colicky pain. It's poorly localized. You can get colicky pain in your bladder, for example. So if anybody's got, experience of having things like cystitis from a water infection, you often get spasmy pain in your bladder that will come and go and might be associated with when you pass water. So raised intracranial pressure, a particular sort of pain that might be associated with having a really bad headache, that's worse with coughing or bending. Yeah, it's always said that it's worse early in the morning, but having looked after lots and lots of patients with raised intracranial pressure headaches, not many of them say it's worse in the morning, but sometimes it is, and might be associated with feeling sick or with visual disturbance, could be associated with confusion or weakness in a focal part of your body. And then we've got things like gastritis and esophagitis, so heartburn type pain, epigastric pain. People might be taking medicines that could make that worse, like non-steroidal anti-inflammatory medicines, so ibuprofen, diclofenac, that sort of thing. And you might find that that's relieved by food like milk, or eating reduces the acid in your tummy. Okay. So symptom management, EMA is a Robert Twycross little an acronym that is quite helpful in an approach to pain. Evaluate and try to diagnose the pain before you treat it, and explain to your patients and families why you think this pain is occurring. Management's individualised. You need to monitor and continually review. And attention to detail is about making sure that you've got all of the information. So going over exactly what medicines patients are taking, what doses they're taking, what else is going on in their lives, how they're feeling, and how things compare to the last time that you saw them. So PQRST is one of the ways that you can assess pain. Other people might know things like Socrates, which is the same sort of thing. It's a reminder of the kind of questions that you might need to ask somebody who's in pain in order to try to work out what's causing it. And if you can work out what's causing it, you're going to be in a much better position to try and treat it in an effective way. So P for palliative, what makes it better? P for provocative, what makes it worse? We've talked about bone pain being worse on movement, haven't we? What's the pain like? We've talked about neuropathic pain being burning and stinging. Does it spread anywhere? So if you had pain from a bone secondary in your back that was starting to affect your nerves or spinal cord, you could get something called radicular pain, which means that the pain is in your back but can start to spread around your ribs, like tightening a belt if it's at one level, or tightening a bra if it's slightly higher up. How bad's the pain? How does it affect you? What does it stop you from doing? Is it there all the time? Is it there any worse? Is it worse at any particular time of day? So quite important to try to examine patients when you can. I know lots of us are working remotely and doing assessment over the phone, and some people are formally trained to examine patients and some people are not. I would encourage people to become formally trained in examination if that is in keeping with your clinical role. Because it's a very useful thing to be able to do. And as I have said on the slide, it does establish trust, and is a sort of, is hands-on care, if you like. If you're assessing people remotely and, some assessment does have to happen remotely, I completely accept that, but you do need to be aware that you may not be getting the full picture, and perhaps the first time or when it's a new symptom, it might be good to try to have a face-to-face assessment where you can examine someone. Okay. We've already said that many patients have more than one type of pain and you have to reassess regularly as the situation changes, often from day to day. I think in my role, just as an aside, I can't always go and see everybody face to face. I'm often advising people like district nurses or GPs or specialist palliative care nurses that work with me. And so sometimes we are doing the assessment between the two of us, really, and I'm relying on someone else to do the examination and let me know what they find, and then we can make a plan between us. But I would beware of trying to do everything over the phone or virtually. Okay, and just to bring all of that together, so we have pain, we've talked about causes in terms of the disease itself, the treatment, something else that's unrelated, or general frailty and debility. We've talked about pain as having physical, psychological, social and spiritual components. We've talked about PQRST and the sort of assessment questions that you might need to ask. And we've talked about the different mechanisms that cause pain, nociceptive, neuropathic, and things like colic, raised intracranial pressure and other sorts of pains. So it's all trying to amalgamate all of those things together. I'm really sorry if that all sounds complicated and quick, but it's just worth, lots of you are doing all of this stuff in your day-to-day clinical jobs anyway. And for anyone where it's a little bit new, you will learn to do all this stuff almost as second nature when you start speaking to patients and assessing them. Okay, so really important message: pain's a symptom and not a diagnosis. So if someone tells you they've got pain somewhere, the key to providing effective pain relief is to diagnose the cause. So you wouldn't want to automatically, if a cancer patient tells you they've got severe pain, increase their morphine, for example. You'd want to know exactly what was causing that pain if you can, because you'll be better placed to treat it in an effective way then. And all of the questions and assessment stuff that I've talked about will help you to be able to try and diagnose the pain or the cause of the pain. Okay. Really important to explain things because it establishes rapport. It helps you to assess where your patients and their families are at, so you can communicate effectively with them and try to explain things in a way that's helpful. So the doctor was a bit baffled why I was in so much pain. He couldn't find anything. We went home and I was really upset. When I was a really junior doctor, I can remember I used to sort of assess people with abdominal pain, for example. You would do your history and examination, not be quite sure what the pain was, but perhaps be wondering if it was something serious, get a scan done, have people back to clinic, and then I'd have the job of telling people what was on the scan. And when it was breaking bad news, that was difficult. But sometimes if the scans were normal, I fell into thinking, well, this is great. I can tell this person that good news, your scan's absolutely fine. So we're all good. And I think I hadn't realised that's often a real disappointment for patients and families because it doesn't explain things to them. So it's not something that they can explain to themselves and then be able to deal with. It's really difficult. And I would find myself in the position of saying, well, the good news is that this scan doesn't show anything that's serious. It's not to say we don't need to do more scans and tests, and it's not to say that I don't appreciate that you've still got the pain. So explaining things in a way that's understandable. I think this pain might be due to nerve damage. That could be why the morphine isn't working so well. We might need to use more than one type of painkiller at the same time. That could help. So just explaining what you're thinking. In lots of people's minds, morphine is the strongest painkiller you can possibly get. So if you take it and it doesn't work, then you might be really frightened and anxious that nobody will be able to get on top of your symptoms for you. Okay. So many different factors contribute to pain. Holistic approach is required. You could modify the pathological process. And this is a cancer example, really, in that you might be able to operate on someone, give them radiotherapy, chemotherapy, hormones. You might be able to alter the thing that's actually causing the pain. You might be able to alter the environment around somebody. So limit the amount of movement that they're having to do if they get troublesome bone pain when they have to walk. Immobilize the painful part. Give my AHP colleagues would assess and provide sort of walking aids, wheelchairs, hoists, and different equipment that might be helpful. So you can modify the process, modify the environment. And then in terms of symptom control of pain, medicines are not always the answer, and non-drug methods can be really, really helpful. So not only the physical stuff like TENS or heat pads and that sort of thing, but all the psychological stuff, explanation, and talking to people about relaxation type methods. Complementary therapies such as aromatherapy and reflexology can be very relaxing and anxiety reducing. I'm lucky enough to have a really experienced clinical hypnotherapist here that can be very effective in giving people coping strategies in order to manage pain, and distraction and psychological support. So all of the non-drug methods are really, really useful. And then you've got your analgesics, which we'll talk a little bit more about as we go. So painkillers, analgesics, about the right drug in the right dose at the right time intervals. Oral, if possible, if people can swallow tablets or medicines, there's no reason why we shouldn't use the oral route. If someone's in constant pain, then they need regular analgesia. I'm talking about palliative care patients here and not straying into chronic pain patients or anyone else who's got pain for any reason. But for palliative care patients, regular analgesia if needed. And by the ladder, and I mean the analgesic ladder that I think is probably on the next slide. So WHO analgesic ladder, this was originally for cancer-related pain, and in more recent years has been questioned and challenged, but I still think it works reasonably well as a basic approach to pain in cancer and in palliative care. That we might start with something simple, such as paracetamol or non-steroidals as an add-on if no contraindications. If regular paracetamol works to a point but doesn't seem to be enough, we might move up to a weak opioid, something containing codeine, so cocodamol, for example, combination of paracetamol and codeine. And then if your weak opioid isn't helping, we wouldn't change to a different weak opioid or go round and round on step 2 of the ladder. We would probably then step up to a strong opioid such as morphine or one of the other strong opioids. And we'll talk about why we sometimes don't use morphine but use alternatives in a minute. Don't worry if this is confusing slide, but what differentiates the strong opioids? Why don't we always use morphine? So morphine would be our first line strong opioid for most people. That's the one we know the most about. It's the one that's most available. It's the one that's cheapest, and it's the one that's most often really, really effective. So morphine works on opioid receptors, interrupts those pain messages going from whatever it is that's hurting up to your brain. And there's different opioid receptors that have got mu, kappa, delta names there, but don't worry too much about that. One of the problems with morphine is that your body breaks it down into sort of metabolites or different bits of morphine, really, in order to get it out of your body and excrete it. But the different metabolites from morphine are also quite active. And morphine gets out of your system by being excreted through your kidneys. So if, for example, your kidneys don't work very well, if you've got renal failure, then the morphine can build up and up and up in your system. You can accumulate it and start to get quite toxic from your morphine. So morphine toxicity, what I mean is things like excessively drowsy and twitchy, and sort of just not able to clear the strong opioid from your system. So morphine comes from poppies, been around for centuries. Fentanyl, as an alternative, is a synthetic opioid, so made in a lab. And so it's not an old-fashioned sort of naturally occurring dirty substance, if you like, that hits all those different receptors. It's designed to just work on one type of opioid receptor, and the type of opioid receptor that's one of the major modulators of pain. So the idea is that it would work better for pain, but not give you all of the other side effects that you get. It's also not excreted from your body by your kidneys, but is excreted by your liver. So it's good for people that are very sensitive to morphine and get very sleepy or twitchy. It's also good for people whose kidneys don't work very well, because it's your liver that gets rid of it. And oxycodone, similar to morphine in terms of the receptors that it hits. The metabolites of oxycodone, when your body breaks it down, are not particularly active. So you accumulate less of those, get less toxic, and it's slightly better for people whose kidneys don't work very well. But I wouldn't say it is safe for people with renal impairment. It's just sometimes slightly better than morphine. If you want a safe drug for renal failure and renal impairment, then that would be fentanyl, because it's got rid of from your body by your liver. Okay, so the severity of pain dictates the strength of the analgesia, and the physiology determines what adjuvants you use. When I say adjuvants, I mean things that weren't part of our analgesic ladder. So not paracetamol or codeine or morphine, but other things that we use as painkillers that we're going to talk about in a minute. And treatment of specific sort of pain. Visceral pain is another word for nociceptive pain. Opioids would be a first line treatment, assuming that you've gone up the ladder and got to step 3. And then you might use other things like steroids. Celiac plexus block in there is very specific, I know. Things like nerve blocks might be worth considering. Celiac plexus is your upper bit of your abdomen. So celiac plexus block is something that we sometimes use for people with things like pancreatic cancer pain.
Jo, can I ask a question, please?
Of course.
It's from one of the delegates. At what stage of CKD would you consider using fentanyl first line over morphine, for example?
Yeah, so if you've got renal function, it would depend on your EGFR and also how quickly things were changing. So if I had somebody with an EGFR, and I'm hoping that I'm sure most of our attendees know what I mean by that. If you had an EGFR below about 30, for example, then I'd probably be thinking about oxycodone as an alternative to morphine. I might think about it slightly earlier than that. And I would be cautious about doses and cautious about the dose intervals as well. So we often use morphine hourly or 2 hourly. We often use oxycodone hourly or 2 hourly, but if I've got someone with significant renal impairment, I might say 4 to 6 hourly, depending on how the pain is. Whereas people with lower EGFRs, and I've got a patient at the moment who's dying from renal failure, whose EGFR is 6, we're using fentanyl for him because it's a much safer drug. So why wouldn't you automatically use fentanyl if it's a much safer drug is the obvious next question. And we're going to come on to that in a minute, but it's because it only comes in patch formulation. People are unfamiliar with it if you put it in syringe drivers, and it's much less easily available. I hope that answers the question. I can't see the question, sorry, Charlotte, so I will rely on you to interrupt if that's okay.
Absolutely fine.
Thank you. So for bone pain, you would go up your analgesic ladder as we have before, but might also think about things like radiotherapy and non-steroidals or bisphosphonates, or sometimes even surgical fixation of pathological fractures. Neuropathic pain, so we co-analgesics, I mean things like amitriptyline, gabapentin, sometimes steroids. Spasmodic pain, so colic or spasms, we would sometimes use things like buscopan, which is an anticholinergic drug that tries to stop spasm, if you like. And then there are lots of specific things here that you might sort of treat the cause. So if we think you've got something that's very inflammatory and infected, like, you know, an infected pressure area, for example, or abscess that's giving you pain, then treating it with antibiotics will be good symptom control. And so even if somebody is in a sort of very towards the end of their life and in a very palliative situation, you might still treat with antibiotics if you thought it was going to give good symptom control. Okay. And gastritis, you might think about antacids or PPIs and stop anything that's making it worse would be a good premise for any of these pains. Okay. So I'm just going to pause for breath for a minute. I'm going to let people have a read through the case study 1, and we're going to spend the second half of this, if that's okay, just going through a case. And I'm going to try and make it slightly more interactive. I'm sorry, it's lots of quick fire slides and me talking. So please do put things in the chat, and please interrupt Charlotte if needed. So I'm just going to have 30 seconds to have a drink. If you want to ask me anything so far, please put it in the chat. I think I drank the Coke too quickly then. Okay. So if there aren't questions, have a think about this. A 60-year-old man with metastatic prostate cancer and continuous pain in his right hip, unrelieved by 8 tablets of cocodamol, 3,500 in 24 hours. What are the options for managing his pain, and what changes in his analgesia would you suggest? Can I ask you to put some comments in the chat for me? And I'm afraid, Charlotte, again, I can't see unless I change my view. So when people have had a chance, maybe you could tell me.
Absolutely. There's nothing there at the moment, Jo, so we'll just give it a few moments.
We'll give it a few minutes. I'll have some more Coke, hopefully in a slightly slower way, or otherwise I'll be hiccuping through the rest of it.
So we've got one that says NSAIDs.
Yeah, good thought. So non-steroidal anti-inflammatory tablets, good. If there's no contraindications, they would be a good medicine to think about in this situation. We are assuming that the right hip pain is coming from bone secondary, and we've already talked about non-steroidals as being potentially good for bone pain. So yeah, good thought. The problem with non-steroidals, as I'm sure lots of people know, are there's lots of contraindications. So they shouldn't be used by people with active gastric or duodenal ulcers, or people at high risk of ulcers or GI bleeds. They shouldn't be used for people with significant renal impairment, and you would need to monitor renal function if you're putting people on non-steroidals. And they also don't help people with things like cardiac failure. So I always say if no contraindications as a caveat for using non-steroidals. Anything else?
Nothing else at the moment there, Jo.
Shall I carry on then?
Yeah.
Okay, so what are our options in managing his pain? And there are many things that you can do, and we will come to all of those as we go on in the case study. What changes in his analgesia would you suggest? So we've talked about our analgesic ladder. We've talked about codeine, which is the major component of cocodamol. Cocodamol's codeine and paracetamol. And if you're using cocodamol, there's 500 milligrams of paracetamol in each tablet, so you are limited to 8 a day, unless you want to split up the paracetamol and the codeine, in which case you could increase the dose of codeine, but this gentleman is already having 30 milligrams of codeine in every tablet times 8, so he's getting 240 milligrams of codeine in 24 hours, and I would suggest it's probably time to step up to step 3 of your analgesic ladder. He's had a fair dose of a weak opioid there, and you would probably be wanting to think about a strong opioid. Morphine would normally be our first line strong opioid, and so this is somebody that I would be thinking about starting on morphine. Okay, so there are different ways that you can do that. You could give him some Oromorph to take as an as required medicine in addition to the cocodamol, and ask him to keep a record of how much Oromorph he was taking and whether it was effective, and then go back and review and amalgamate your pain control in some way, possibly into a long-acting opioid like MST or Zomorph. Or you might swap from the 8 tablets of cocodamol a day straight onto sort of long-acting morphine preparation, in which case where do you pick your dose? And that's what's on my next slide. Okay. Does anybody want to put themselves on the spot? And if you were changing from regular cocodamol in this dose to something like MST or Zomorph, where would you start in terms of dosing? Let's see if anyone's brave enough to put that in the chat.
Yeah, you can either pop it in the chat or we can unmute you and you can sort of, if that's a bit less scary.
Or I can tell you my thoughts and you can challenge me if you wish.
Nothing there at the moment.
Shall I carry on?
Yeah.
Okay, so this is our analgesic ladder. We talked about going up to step 3, strong opioid. We talked about morphine being the first line strong opioid. So 240 milligrams of codeine in 24 hours. So morphine is probably, as far as we can tell, about 10 times the potency of codeine, 10 times as strong. So this person's getting 240 milligrams of codeine, which is the equivalent of about 24 milligrams of morphine in 24 hours. So if you were going to change that into a 12-hourly formulation, it's probably about 12 milligrams twice a day of MST or Zomorph, which of course don't come in 12 milligram formulations, but I'm just pointing out that that is the equivalent dose. So you'd probably use 15 twice a day of MST if you wanted the same dose. For this patient, we've already said that that amount of analgesia isn't quite effective enough, so you may want to go up a little bit. So something like 20 milligrams of MST, perhaps, with Oromorph as a breakthrough analgesia. I think my point with this slide is it wouldn't be advisable to start on the smallest doses of strong opioids. So I hope you can see from this slide, it probably doesn't make sense to start on 5 milligrams twice a day of MST, because you're effectively reducing this person's analgesia then. So in all likelihood, that's not going to help their pain and might actually make the pain worse. So you do need to have sort of the ballpark figures in mind, really. So yeah, your equivalent dose is probably about 15 BD of MST or Zomorph. So if you want to go up a bit, which would seem sensible because this person's in pain, then we're talking about maybe 20 milligrams twice a day of MST or Zomorph, and to stop the cocodamol. Paracetamol component works in a slightly different way, and what we sometimes do is stop the cocodamol but change that person onto regular paracetamol and adds the morphine in, so they're getting 2 different types of analgesia there, because the paracetamol component might be helping. Okay, so we've done that, divide by 10. Okay, so we select analgesia for the most appropriate route, oral, unless there's some reason why people can't take things orally, either because they're vomiting or because there is something wrong with their esophagus, stomach, or something that means they can't swallow or can't keep medicines down. They've got bowel obstruction, for example, or if they're so unwell that they can't take tablets and can't swallow properly, and those patients might well need medicines via a subcutaneous route or something like a syringe driver. We've talked about needing to bear in mind conversions or equivalent doses. Always good to try and establish a rapport with patients and to try and explain to them that you do need to know honestly what they're taking, and if they're not taking something, we need to know that as well. I've seen several patients come into the hospice where pain control's been poor. They've told us what they're taking, or we've assumed that we know what they're taking, so we've increased analgesia, and they've suddenly become very sleepy or very opioid toxic. And when we look further, it turns out they weren't taking all of the stuff that we thought they were taking in the first place. So we've inadvertently increased things a lot and tipped them over the edge into opioid toxicity. We've talked about renal and liver failure as being important to think about when you're choosing your analgesia, and you always should have, if you're on long-acting painkillers, should always have breakthrough analgesia available. So our gentleman in our case study then, we started him on MST 15 milligrams BD, which was increased over the last 8 weeks to slowly titrated up to 60 milligrams twice a day. He's generally better, but has times in the day when the pain is severe. He's taking Oromorph 10 milligrams as required and has used 4 doses in the last 24 hours. Options, or does anybody want to comment on what they might do? Or Charlotte can let me know if she just thinks I should carry on.
Give it a couple of moments. Alternatively, you've all got my email address if you don't want to type it in front of all colleagues and risk, feeling exposed by it.
I promise there's not always a right answer to these things, and in palliative care, there's usually several different ways around any problem or several different approaches. The people who work in specialist palliative care on this call will know that there's always a slightly different way of doing things. Or they'll work with one colleague that does things one way when they start in palliative care, and they'll learn that, and then they'll go to work somewhere else or with someone else, and they'll have a different approach, and then they'll be questioning what's right and what's wrong, and the answer is there's more than one way to skin a cat, really.
I think we'll move on, Jo, and if anybody pops anything in, I'll just interrupt you.
There's lots of different options here. Again, more than one way of approaching it. I think it's probably worth thinking about breakthrough doses. So this gentleman's on 60 milligrams twice a day of morphine. It's gradually gone up. And so is the Oromorph breakthrough dose adequate is one of the questions that I would want to ask. And then is he taking it, and then does it work? And we often get people to keep a little pain diary, don't we, in palliative care, or a little notebook that, and those people that are good at doing their homework proudly present to you when you speak to them or when you go and see them. So breakthrough pain is pain, as it says, pain that breaks through the background painkillers that you have got. There's different types of breakthrough pain that I won't much go into here, but there's predictable breakthrough pain, which is something like, I know it's going to hurt when I move because my hip always hurts when I move. So pain that hurts when you do a specific thing, we sometimes call incident pain. And for that sort of pain, you can sometimes take some extra analgesia before you know that you're going to do something that hurts, rather than increasing your background and having that higher level of painkiller for the whole time. Okay. Sometimes breakthrough pain's a bit worse at the moment, and I don't quite know why, and I just need a top up of my immediate release morphine that goes with my MST. We use 1/6 of the total 24-hour dose of opioid just as a rough guide in calculating breakthrough pain. Patients are individuals, aren't they? And, you know, it shouldn't be an absolute strict rule of 6, but it's quite a good ballpark figure in deciding how much breakthrough stuff people need. So for 60 milligrams twice a day of MST, a 1/6 of the total daily dose. So that person on 60 BD of MST is on 120 milligrams of morphine as a 24-hourly dose. So if we're using a 1/6 of that as a breakthrough dose, then we'd be wanting to think about something like 20 milligrams of Oromorph as a breakthrough dose. And in the previous slide, I told you that a patient's only taking 10 milligrams of Oromorph. So, you know, it's probably quite a good idea to increase the breakthrough dose into something that's more like a 1/6 and see if that's effective. So we sort of use a 1/6 as a rough guide for oxycodone as well. So somebody on 30 milligrams BD of OxyContin, the total 24-hour dose of opioid is 60 milligrams of oxycodone. And so that person's breakthrough dose is probably in the order of about 10 milligrams of some formulation of immediate release oxycodone. So short tech or Oxynorm or something along those lines. And also works for syringe drive as an alternative route. So somebody with 120 milligrams of morphine in a syringe drive, for example, so that's their total 24-hour dose, isn't it? And a 1/6 of that would be, again, 20 milligrams. So 20 milligrams of subcutaneous morphine is probably an appropriate breakthrough dose for that person. Okay. Charlotte, I'm relying on you to stop and ask if there are any questions, if that's okay.
Absolutely.
Yeah. So we've already talked a bit about background pain and breakthrough pain, so I won't dwell on that, but a transient exacerbation of pain, spontaneous or in relation to something specific, so a predictable or an unpredictable trigger, despite relatively stable and adequately controlled background pain. Okay, we talked about what incident pain was, didn't we? Titrating morphine in palliative care, if you're monitoring your patients and titrating them in a slow but cautious but effective way, then morphine should be safe. There should be a window there between being in pain and having opioid toxicity. It's more likely to be a window in things like nociceptive pain, whereas we've already said that things like neuropathic pain, you might need to add in other painkillers in addition, and morphine in itself may not be able to be completely effective. Okay, so gradually titrating up morphine will hopefully get the levels into this window here that's below being toxic but above the threshold that you need for pain control. Lots of people are very anxious about taking morphine. There's lots of myths out there about morphine, that I'll become addicted, or it will just make me asleep the whole time and sedated, or that if I start taking morphine now, when the pain gets really bad, when I'm worse, there won't be anything that will work. And so there are lots of those myths, and it's important to talk through those with patients and to say that you know, addiction is not something that we see as a particular issue in palliative care in people that are using small doses of carefully titrated opioids under the monitoring from either, you know, their generalist teams or sometimes some specialist palliative care. Addiction is not normally an issue that we see. Tolerance is not normally an issue that we see either. So tolerance means that you need the same doses, you need an increased dose to get the same effect. So you wouldn't need more and more and more and more morphine to get on top of your pain if your disease itself was stable. And the people who we do find are needing more painkillers are usually those people, when you do a scan, would find out that their disease is progressing. So I've got patients who've been on a stable dose of morphine for many, many, many months with stable disease. So you don't have to go up and up and up all the time. Okay. People worry about, you know, our friend Dr. Shipman from many years ago, who we think murdered hundreds of his patients by, well, we don't quite know, different methods, but using large doses of IV diamorphine was one method that we think he used, so that you can see what happens if you give somebody a big dose of IV morphine or diamorphine. You get this huge big peak here that's well above the toxic level and can stop people from breathing. This is the sort of thing that's happening with people who are drug users of opioids and are mainlining things like morphine, heroin, fentanyl, getting this big peak, and that's what people are chasing really with the psychological high, but it's also very dangerous. With our patients, if you can remember, we were within that window, or we hoped we were, between the pain threshold and toxicity, and that's what makes it safe. Okay. Also, Dr. Shipman's patients often didn't have any pain present, and he wasn't treating anything in particular. Okay. So the next bit of our case discussion then, I can see that James has joined us, so you can feel free to chip in, James, as well, as we're going through if needed. So our gentleman's on 60 BD of morphine. He's become very sleepy during the day, but had quite good pain relief. The number of breakthrough doses is a little bit variable. So what are our options now? So I think what we're thinking is that he is probably becoming sleepy because he's on his strong opioid and the dose has gone up, and he's maybe reached what he's able to tolerate without troublesome side effects. You do need to check that there's no other reason why he's sleepy. Is he septic? Has he got a high calcium? Is there something else going on? What other medicines is he taking? Has he been taking the correct doses? Has he been, accidentally overdosed? But if you've excluded all of those things, then it may be that he's starting to get troublesome side effects from his strong opioid. And if that's the case, what are options? I'll move on in the interest of time. So we talked about the alternative opioids having slightly different receptor affinities and slightly different side effect profiles. And so, which strong opioid might you use? Oxycodone is probably our most common second line opioid to be used. We talked about some of the slight differences in that it doesn't have active metabolites that accumulate, so it might be slightly safer in things like renal impairment, but not, as before, not a safe drug in severe renal impairment or renal failure. Fentanyl, trickier to use because it only comes as patches or injections, so you can't easily titrate people on painkillers using patches because they take 3 or 4 days to get to a steady state, and so if someone's in severe pain, it's going to take 3 or 4 days for them to have their full effect, so that's no good to us. And buprenorphine, again, useful drug, but comes in patch formulation in general, so hard to titrate. And that's a link to an opioid dose converter that is helpful to talk about conversion doses. So oxycodone is our most common second line opioid, but it's worth considering the dose equivalence of fentanyl patches because it's often more than you think. So a 12 microgram per hour fentanyl patch is the equivalent of about 30 milligrams of morphine a day, or 15 BD of MST. So it's a reasonable starting dose. And that's why before the 12 patch was available many years ago, people used to start straight onto 25 or 50 microgram patches sometimes, prescribed by perhaps colleagues that were less familiar with the conversion doses. And so they wouldn't quite realize they've actually started somebody who could be opioid naive on a very big dose of opioid. So it's worth bearing in mind the conversions there. We'd often use Oromorph as a breakthrough if someone's on a fentanyl patch, and so this conversion also helps you to work out a 1/6 of your total daily dose for the breakthrough. Okay, so we've converted our patient because he was quite sleepy onto oxycodone. Oxycontin is modified release 12-hourly oxycodone. At the moment, certainly within Cardiff and Vale, we are using Longtec, which is just another trade name for modified release oxycodone. And 10 milligrams of PRN oxynorm is an appropriate breakthrough medicine and an appropriate breakthrough dose for this gentleman. But on that, he's become less sleepy and been stable for the last couple of months, but now got escalating pain, burning pain in his right hip, radiating down his leg to his foot, like walking with a pebble in my shoe. So what type of pain do you think that might be, and what are our options? Now it's coming close to 3 o'clock, so I'll give you 10 seconds to type something if anyone's brave enough, and I'll get James or Charlotte to move me on. If not, I can't see the chat, I'm afraid.
There's no responses to that in the chat, but we could unmute James if he wanted to add anything or sort of respond.
I'll take that as a no for now then, James. All right. So I hope from what we talked about before, you can see that the burning nature of that pain and the fact that it's radiating down his leg to his foot may mean that it's neuropathic in nature. It could also be bone pain, couldn't it? Because we've talked about the pain coming from his hip, and that's what we were assuming at the start when we started him on a non-steroidal. If we thought this was neuropathic pain, what options might we have? So we sometimes use steroids for neuropathic pain or for nerve compression, and they often work quite well because of their anti-inflammatory nature. You need to be careful with steroids for people who are diabetic, for example. And also, we can't have people on steroids for long periods of time. And we also, if you've been on steroids for a moderate amount of time, can't suddenly stop them. So they're probably not a good drug to think about unless they are a temporary measure, if you like, while you think about something else. So you might start someone on steroids while you also start them on something else, like perhaps amitriptyline or gabapentin, that will be a longer acting medicine that they could stay on, and then you could tail the steroid off. Or we sometimes think about steroids while we're waiting for radiotherapy, for example. Or we sometimes would just trial them on a temporary basis. But if they work, then you've often got the problem about whether you continue them and put your patient at risk of all of the steroid long-term side effects, or whether you then try and tail them off and what you're going to replace them with. So gabapentin or amitriptyline or pregabalin are some of the common adjuvant analgesics that we use for neuropathic pain. This box here is probably in the realms of specialist palliative care, where we might think about things like ketamine is an MDA blocker. And then you've got spinal analgesia and things like single shot epidurals, or more recently we've talked about intrathecal pumps, which can have things like local anaesthetic and opioids in. Okay, so for our patient, he's had an MRI scan because we were worried that he could be compromising his spinal cord with pain going down his leg and affecting his foot. This showed nerve root compression. He's had radiotherapy and completed a course of steroids. And he's also had gabapentin added into his analgesia there. And the neuropathic pain's controlled, but he's still reporting walking with a pebble in his shoe, notices a dull ache in his right hip, worse on walking, no radiation. What are we then going to do? What are we worried about? I won't ask people to put stuff in the chat because I know we need to move on in terms of time. So this is where you need to have attention to detail. You need to constantly think what's happening now. You need to go back and assess your patients, talk to them, ask them all of those questions in the history that we talked about, examine them, and think about whether you need to do any other investigations in terms of, imaging or something like that. So for this gentleman, for bone pain, we talked about strong opioids and non-steroidals already. Radiotherapy is often very helpful. Palliative radiotherapy for bone pain is relatively easy to organise, but has to be done in where the radiotherapy machines are. So for us in South Wales, it's Felindra or Swansea or the North Wales Cancer Treatment Centre. And therefore you've got the sort of upheaval, if you like, of getting your patient from where they are to the radiotherapy machine. Where I work, it would often take at least 2 journeys, one for planning and one for treatment. And for palliative radiotherapy, our oncology colleagues would often try to treat in a single shot if they could. But whether you have to go for repeated daily treatments depends a little bit on what you're treating. Bisphosphonates can be helpful for bone pain, but not immediately. If they do work, they may take sort of several weeks to work. So I'm talking about things like Zamita. Orthopedic procedures. If you have bone pain in your femur, for example, you do an X-ray and there's a big metastasis, big lytic lesion, a big hole, if you like, in your femur that looks like it could be about to break. Then if your patient is fit enough and it seems appropriate, having an orthopedic surgeon to prophylactically pin that will not only stop it from breaking, but can also be really helpful for that movement-related pain. And radionuclides, our patient's got metastatic prostate cancer, hasn't he? So that old-fashioned things like strontium used to be used, and now it's radium, and I've forgotten the number, but an isotope of radium where it's an injection of isotope that's radioactive, if you like, and is preferentially taken up by the bone secondaries. And the radionuclides will then hopefully work on the bone secondaries and reduce the disease in those areas and therefore help the pain. Talked a little bit about bisphosphonates like Zamita. They're also used to treat acutely to treat high calcium that's associated with cancer. You have to monitor renal function. You have to make sure people don't get a low calcium if you're treating them. You also need to think about bone health and vitamin D and things as an add-on. And acutely, when you're having them, they can make you feel a bit unwell, flu-like, and can give you a flare of pain in the immediate aftermath. And one of the main side effects, or things that we worry about, are osteonecrotic side effects. So people can get things like osteonecrosis of the jaw. They're on these things longer term, especially if they've got poor dental health. Okay, back to our patient. He's had a non-steroidal added in. I put diclofenac there. We are using some of the newer and COX-2 selective non-steroidals now, so things like celecoxib. You may see used within palliative care, partly to try and limit side effects. He's still walking with the pebble in his shoe and a walking stick, is out and about, and telephones to discuss a pain in his lower leg. Should he adjust his OxyContin dose? And it's tempting and not necessarily the wrong thing to do to say, okay, well, let's increase that and see if it helps. But that shouldn't be the only thing that you do. You should be assessing as well as you can. You need to think about whether you need to physically see him in order to examine him to see what's actually going on and whether something else is needed. Because if you were to do that, it could be that you'd find something like that. I don't know how well that portrays. This obviously isn't our patient, because the observant people among you will notice that this is a lady and not a man's X-ray. And I don't know how well you can see that, but this person's got a broken hip. And certainly with pathological fractures in the palliative care patients, they sometimes don't manifest themselves like a broken hip. If you fell over and had trauma and had your, you had severe pain and couldn't walk and had your hip shortened and rotated, pathological fractures can sometimes be quite subtle, and people will sometimes, just have gradually increasing pain. So we sometimes do need to investigate. Okay. So if things aren't working, review the cause. Has the situation changed? Are they taking the right medicines? Are they still managing to absorb them from the route that you've selected? Do you need add-on analgesia, not just morphine? Or is it an element of total pain? Is it that they're very low in mood or very anxious or very frightened, or there's all of that existential stuff going on? So there's some of the reasons why analgesia might not be working. Okay. And that's just a slide there for further information and advice. So within the Cardiff and Vale area, clinical advice in hours comes from either City Hospice if you're in the city of Cardiff, or Marie Curie if you're in the Vale of Glamorgan. And those of you who are from elsewhere will be from your own local palliative care teams. And if you don't know, you should just double check how to get hold of them when you need them. In this health board, out of hours medical advice 24/7 is available through Cardiff and Vale switchboard. I've given you the opioid dose converter there, and the palliative care formulary is a palliative care version of the BNF, if you like, that gives you lots of information about medicines. If you work in secondary care, your local hospital pharmacy should have access to. Thank you. I'm going to stop there because we've gone over time slightly, and hopefully stop talking for a little while. I'm going to stop sharing my slides, Charlotte, if that's okay.
That's good. Shall I stop the recording?
Yeah, I think so. Is that all right? So someone's asking,
Yeah.
please can the slides be